This talk is about splenic infarction. Located in the abdomen, directly beneath the diaphragm and connected to the stomach, the spleen is the body's largest filter of the blood. The two major functional zones of the spleen are the hematogenous red pulp and the lymphoid white pulp. The white pulp is the main function of white pulp carries immune function, whereas red pulp is removing aged and defective RBC and also storing breakdown products of RBC such as iron. And also, in addition, spleen have additional jobs such as erythrocyte production in the fetus, stores blood platelets, and has regenerative properties. The spleen receives most of its arterial supply from the splenic artery. Splenic artery arises from the celiac trunk, a short vessel arising from the aorta. So splenic artery is a branch of celiac trunk. Celiac trunk is a branch of aorta. As the artery reaches the spleen, it branches into 5 vessels, each supplying different parts of the organ. These arterial branches do not anastomose with each other, giving rise to vascular segment of the spleen. So this enables a surgeon to remove one of the segments without affecting the others, a procedure known as subtotal splenectomy. Venous drainage occurs through the splenic vein, which combines with superior mesenteric vein to form the hepatic portal vein. A splenic infarct is caused by occlusion of the splenic artery or one of its branches, resulting in tissue necrosis. They are caused by a variety of potential pathologies. However, fortunately, splenic infarctions are rare events. In addition to splenic artery, the spleen gets blood supply from short gastric arteries. So, most of the time, infarction is often not complete due to the collateral circulation from the gastric arteries. We came to etiology. The most common cause of splenic infarctions are hematologic disease or thromboembolism. Hematologic disorders such as lymphoma, myelofibrosis, sickle cell disease, chronic myeloid leukemia, polycythemia rubra vera, or hypercoagulable states are the most common one. Hematologic disease causes infarction through congestion of the splenic circulation by abnormal cells, often further confounded in conditions such as CML or myelofibrosis by anemia and splenomegaly. Embolic disorders such as endocarditis, atrial fibrillation, infected aneurysm, or post-MI mural thrombus can also predispose for this. Other rare causes include vasculitis, trauma, collagen, tissue disease, or surgery, such as pancreatectomy, can predispose for splenic infarction. Classically, symptomatic patients will present with left upper quadrant abdominal pain, which may radiate to the left shoulder. Less common symptoms include fever, nausea or vomiting, or pruritic chest pain. However, in a significant number of patients, splenic infarctions can be completely asymptomatic, diagnosed purely by imaging or exploratory surgery. On examination, left upper quadrant tenderness is common. Other signs might be present depending on any complications that have developed. Regarding differential diagnosis and investigation, as with many cases of acute abdomen, there is a wide range of differentials to consider, narrowed down through clinical features and investigation. However, important common differentials to consider for left upper quadrant pain include peptic ulcer disease, pyelonephritis, urinary colic, and left-sided basal pneumonia. The gold standard investigation for suspected splenic infarction is a CT of abdomen with contrast. In addition, routine investigations and searching for underlying etiology is important. When we came to management, there are no specific treatment for splenic infarct. Patients are monitored regularly, ensuring hemodynamic stability with appropriate analgesia and IV hydration prescribed. It is important to identify the cause of the infarction and treat, as well as consideration of long-term anticoagulation. So analgesia, IV fluid, antiemetics, doing echocardiography and ECG, blood cultures, and also coagulation study is very important. Splenectomy should be avoided due to risk of overwhelming post-splenectomy infection syndrome. However, this may become unavoidable if a complication develop or symptom persist. Due to the spleen's role in the protection against encapsulated bacteria, vaccination for most common encapsulated bacteria is advised in extensive splenic infarction. In addition, long-term low-dose antibiotic prophylaxis important or should be considered to clear encapsulated bacteria without spleen. The prognosis of splenic infarction varies enormously depending on the cause and the severity of the disease. Patients with benign underlying disease and asymptomatic infarctus will have an extremely good prognosis. Patients with splenic infarct secondary to hematologic malignancy will have a far more guarded outcome. The most common complication of splenic infarctions are splenic rupture, splenic abscess, and the pseudocyst formation. Most of these cases will need splenectomy. A splenic abscess will be seen post-splenic infarct when underlying cause was from a non-sterile embolus such as infective endocarditis or when the patient is immunocompromised. The embolus seeds infection into the necrotic splenic tissue, but yet clinically this can be difficult to differentiate from uncomplicated infarction, but it can be differentiated by further investigating it. Autosplenectomy is due to repeated splenic infarction, which results in the progressive fibrosis and atrophy of the spleen. When this continues over a prolonged period of time, especially during childhood, it leads to complete atrophy of the spleen, termed autosplenectomy. The most common cause of autosplenectomy is sickle cell anemia, because repeated sickle cell crises lead to recurrent occlusion of splenic artery. If this continues throughout childhood, it can cause complete asplenism by adulthood. Thank you for watching.